Preventing and treating post-traumatic stress disorder within female rape survivors utilizing crisis intervention and cognitive behavioral therapy. And I'm Nicole Tolan. Prevalence of rape and sexual assault in the U.S. It's hard to determine how many women are impacted by the social problem of rape because each study offers different definitions of rape. Some use forcible rape, some use sexual assault, and others use date rape. So in order to see how many people are impacted, you have to look at both the crime surveys, which are conducted by the police, and the victimization surveys, which are conducted by nonprofit organizations such as centers for helping victims combat their sexual assault. Police surveys say about 13% or 12.1 million women are raped in their lifetime. Victimization surveys say between 3 and 24% of people are raped in their lifetime. There's a big difference between these numbers, and that's because a lot of women do not report the rape. Post-traumatic stress disorder and rape. So about 24% of individuals who are physically assaulted show signs of PTSD within 6 months. So how does that compare to sexual assault? 41% of individuals who have been sexually assaulted show signs of PTSD within 6 months. Rape is actually the top cause of PTSD. It's ahead of terrorist attacks and witnessing an event. Symptoms of PTSD. There are lots of symptoms of PTSD. Some are persistent and unwanted memories and dreams. High distress when exposed to triggers, avoidance of thoughts and stimuli surrounding the event. This could cause people to become really avoidant to areas that remind them of the rape, or maybe even friends and family members that might trigger memories. Feelings of reliving the rape. This can happen through hallucinations or flashbacks with dissociation. Other symptoms of PTSD include social isolation, impaired memory, pessimism about the future, insomnia, increased agitation, problems with concentration, and becoming easily startled. It's important to remember that PTSD shows a high functional impairment, meaning someone struggles to function within their family, within their work, within their home, or a combination of all of these places in their life domains. Issues associated with PTSD and rape. There are a lot of important issues that surround the social problem of rape and PTSD. Many women do not report their rape. This is some researchers have thought that this is because of social stigma. They have hypothesized that women do not want all the attention drawn on them and have people know that they've been raped because they might be looked down upon. There's also a high non-compliance rate with follow-up of treatment after a woman has been raped. Clients frequently terminate their services, and people with PTSD symptoms are actually the least likely to receive help initially or even later on than those with milder symptoms of just depression. So it's really important that we as social workers find effective interventions to increase prevention of PTSD, and if we can't increase prevention, we can at least more effectively treat the symptoms of chronic PTSD that people get later on after their rape. Theories, rape, and PTSD. Now there are two theories that are helpful with PTSD. The first one is crisis theory. Briefly going through crisis theory, this theory deals with behaviors and feelings that occur after an acute stressful event in an individual's life. This is also known as a crisis. In a crisis, an individual is unable to utilize their coping skills that they would normally be able to use in order to return their body back to its normal state or homeostasis. It's important to remember again that there's a functional impairment. And then important interventions with crisis theory focus on having the social worker take a direct active role. An immediate intervention, so if someone came into the hospital and reported a rape, they would immediately be provided with social work services and interventions. And then there is a primary emphasis within the crisis theory on symptom reduction and providing community resources and natural supports to help the individual get over their rape. So how are crisis how is crisis intervention associated with rape and PTSD? Well, rape is an inherently traumatic event, therefore it's a crisis. And it's important to remember within crisis intervention, the interventions must be quick to return the client back to homeostasis. So if you do not have a quick intervention that's effective within crisis intervention, there's a high risk for developing PTSD. PTSD is actually the most common psychopathology to develop after a sexual assault. It's higher than depression, anxiety, isolated by themselves, or other psychiatric diagnosis. Also, the majority of individuals with PTSD have experienced rape at least once in their lifetime. Another theory that's effective when we talk about PTSD and rape is cognitive behavioral theory. So briefly going through cognitive behavioral theory, this theory states that there's an activating event, a belief, and a consequence. Now, a negative event does not equal a negative feeling. In CBT, the negative feeling is actually caused by the belief that surrounds the event. So interventions within CBT focus on changing the belief. It doesn't focus on changing the event. So if we change the way we think, we can change the way we behave. The interventions focus on changing thoughts, behaviors, or both thoughts and behaviors. CBT, rape, and PTSD. The most common intervention for our victims with PTSD is CBT. It's shown to be the most effective, and this is done through exposure therapy, where the client is asked to recall their trauma and then change their belief systems associated with the trauma and learn coping skills for the trauma. As an example, a client feels as though she's dying when she has a panic attack related to PTSD. The social worker would challenge the client to examine the belief that she's dying. The client is taught to regulate the breathing while she's having this belief that she is dying, and then ultimately learns that her dying belief is not reality. She's not actually dying. There are many similarities between the theories for prevention and treatment of PTSD. Primarily, they all deal with ways to cope with symptoms and improve functioning. They both involve reality testing and recalling the event. They require the social worker and the client to work together, and they both teach coping skills. Now, there are also very many differences between the theories. Crisis intervention is time limited. It's primarily focused on symptom reduction through a quick emotional outlet, which is also called psychological debriefing. In psychological debriefing, the client is just asked to freely recount their experience. They're not taught to deal with the belief that surrounds their feelings. There's also a heavy emphasis on resources and natural supports. And in crisis intervention, the social worker is highly active and directive. Now within CBT, CBT is typically longer term. It focuses on changing the belief systems around the feelings. And the client is more highly active than the social worker. The social worker is just primarily used as a guide in this type of intervention. Practice principles and interventions. Practice should be based on the understanding of the various strengths and limitations of each theory and how best to combine approaches to respond to particular situations. There's limitations of all of the theories. The limitations of crisis intervention are that the psychological debriefing, which is used in crisis intervention, has actually shown to not be effective. It doesn't reduce the prevalence of PTSD 6 months later, and it actually, in some studies, they showed that individuals who were provided with psychological debriefing had an increase in PTSD symptoms. There's limitations of CBT as well. While CBT is highly effective, there's a very low compliance rate that's associated with CBT. Some possible explanations that have been offered for this are because it's an intensive long-term process, clients don't aren't able to access their therapist because of their schedules, travel barriers, or because they want quicker results. They don't want to sit in therapy forever. There was a study done, and the primary barrier that was found was that the clients struggled to engage with their social worker. An explanation for this was that the inherent nature of PTSD, the avoidance symptom, caused them to avoid to engage with the social worker. So, how do we fix all these limitations? Well, we combine crisis intervention and CBT. So brief CBT within crisis intervention can be used for prevention. So when we first see the client within the crisis setting, we immediately provide brief CBT. We don't use psychological debriefing. There's several studies that have been done that show that this is effective. In one, it was found that the prevalence of PTSD is lower among trauma victims who immediately receive the intervention versus people who wait later. Another study showed that 90% of participants recovered from PTSD when they were given a brief CBT versus only 30% that recovered in the control group who were not given brief CBT. Brief CBT within crisis intervention with treatment. Now, a lot of people are not going to be compliant with treatment after that initial intervention. So if we can't prevent it, we can learn how to better treat it later on. So if people come in and they want a quick treatment or they are having trouble with their schedule, we can provide a brief intensive CBT. This has been shown to be effective. One study provided a week-long brief CBT intensively for several hours every day. There were no dropout rates. And actually, within 3 weeks, 71% of the people did not have PTSD anymore. 86% did not have PTSD anymore at the 3-month mark. And 93% did not have PTSD at the 9-month mark. There's other things that we can implement within our practice to decrease PTSD. There's been a lot of studies done about social support. It's important to remember that one of the primary objectives of crisis intervention is to wrap the client in services, and this has been shown to be extremely effective. There was a study done, and women who had little to no social support struggled to function and were at a higher likelihood of developing PTSD post-rape than people who had moderate to high access to their community and their family. So social supports and natural supports and community resources are critical. Whether CBT is offered immediately in a prevention effort or it is included within a treatment, it's really important that you remember to provide the client with community resources and natural supports regardless of when you're doing the CBT.
Yeah! Hooray! Yahoo! Yeah! Hooray!
So there is hope for alleviating the severe symptoms of PTSD in crisis theory and cognitive behavioral theory. Thank you.